A special thanks to the doctors who will be presenting the cases this morning. First of all, Dr. Hugo Fuentes from Lima, Peru. And we may not be able to see Hugo, but he will be able to speak. So there's something wrong with the camera, but we'll be able to hear him present the first case. Hugo, we'll just take one case from Lima, if you don't mind, and come back at the end if we have time, but I doubt it.
Oh, it's okay.
Dr. Nelly Velikova from Sofia in Bulgaria joins for the first time. Thank you very much, Nelly. And thank you to your colleagues for joining us. And the third duet hasn't come online yet, but Dr. Pierre Ramos, whom we know well, and Dr. Cynthia Villarreal are two doctors in Monterrey, Mexico, who are going to present the third case. So a special welcome and thanks to the panelists as well from MGH and around the United States. Thank you very much, everybody, for joining. Can I please emphasize for first-time attendees to please keep your microphones on mute unless you want to speak, and then you unmute it, and use the toolbar on Google Hangouts and not the mute button on the microphone itself. And as a reminder, all the cases today will be recorded and archived on PowerPoint cases, and there will be a YouTube recording to match it, which will be allied to the case each time. So we cut up the discussion of the panelists and we attach it to the case. We have a new thing this morning that I'd like you all to help us with, please. From today, we're asking you, all our friends attending this tumor board, just to take a minute or 5 minutes at the end of the tumor board to take a group photograph of all the doctors in your room, just with your iPhone, just a picture towards the room so we get a record of everybody attending. That'll help us because for many sites, we don't know how many doctors are entering the room, and so we'd like to record that. So please send them along to Jessica at your earliest opportunity after the tumor board. And with that introduction, I'd like Hugo from Lima to perhaps start presenting the first case. And we can hear your voice, Hugo. We just can't see you. There he is.
Okay, good morning to everybody. We have technical problems with the webcam. Well, this is a case of a postmenopausal woman of 52 years old with family history of breast cancer, her aunt and her cousin with breast cancer. He came to the hospital the first quarter of 2013 with 2 months of history with painful lump in her breast. The mammogram and the ultrasound shows in the upper outer quarter a high density 2.5 by 3 centimeters with pleomorphic and microcalcifications. The biopsy shows DCIS high grade, and she performed a lumpectomy and sentinel lymph node biopsy. The pathology report infiltrate ductal carcinoma with extensive DCIS, and the infiltrative compound represents the 5% of the tumor. The nuclear grade were high, and the size of the invasive carcinoma was 2 millimeters. The surgical margins were in contact with the DCIS. The immunochemistry report a triple negative breast cancer, and 3 weeks later, she had a wide local excision with no residual carcinoma. So we have a stage 1 triple negative right breast cancer, T1B and N0, M0. She put in adjuvant chemotherapy with Taxol weekly times 12 and FAC times 4. Then she received radiotherapy and then follow-up. Next, please. In the mammogram and ultrasound control, in the third quarter 2015, this year, the mammogram report a pleomorphic microcalcifications below the scar in the same breast, the right breast, 19 by 4 millimeters. These were not found in the study of the last year. Positive and central peripheral vascular Doppler. The biopsy report DCIS with foci of microinvasive carcinoma. She had a mastectomy with sentinel lymph node biopsy and breast reconstruction with tissue expander. The pathology reports a DCIS with multiple foci of invasive ductal carcinoma. The largest foci was 2 millimeters, and the DCIS represents more than 90% of the tumor. Stromal fibrosis was found, and the lymph nodes were negative. The immunochemistry reports a triple negative tumor with a Ki67 of 20%. Next, please. Well, there are other questions. The first question is the role of knowing the BCRL mutation status in an neoadjuvant plant, the optimal treatment for no
I tell you what, Hugo, let's take the questions one at a time if you don't mind. So we'll start with the first question. What would, knowing the BRCA, in light of the family history, which wasn't that strong actually, an aunt and a cousin at age postmenopausal at 55, what is the value of knowing versus not knowing the BRCA mutational status in the neoadjuvant plan? So I'm not 100% sure I understand the question.
So probably you didn't mean in the neoadjuvant plan because this patient was treated adjuvantly, but the NCCN guidelines now state that anyone diagnosed with a triple negative cancer under the age of 65, I think, it's either 60 or 65, we do routine testing for BRCA1 or 2 for whatever it's worth. But so theoretically, she would have fallen in that category with her family history and the triple negative nature of her tumor. You know, in our center, patients, it's a choice, but they may at the initial operation have chosen mastectomy bilaterally in lieu of doing the lumpectomy.
Even for what's being presented, I think, is an extensive DCIS with very minimal invasive ductal component, but that would still apply.
Yeah.
I mean, bilateral mastectomy would still be an option as the initial choice. If she was BRCA1 mutational positive or just with her family history?
No, if she was BRCA1 positive.
Okay, she'd been tested.
1 or 2.
So for those doctors on camera here from around the world, Michelle, it's not common to have access to the BRCA1 and 2 mutational analysis. What do you advise those doctors to do in these tricky cases of triple negative and strong family history? Do you have advice for them?
Well, I think that, I guess, to me, it's not such a strong family history. You know, maybe diving down and really being very thorough about, you know, is this a paternal aunt? Did your father have other sisters? You know, really trying to get an understanding of the number of individuals that were unaffected versus the individuals that are affected, and if those individuals exist, to determine the family history.
So Michelle and everybody on camera, it's routine in our setting when a family history suspects hereditary breast cancer to have both counseling and analysis, mutational analysis performed. Does anybody, or would you advise counseling, as they don't have financial access to the mutational analysis, would you advise a counseling clinic even so to do the deeper dive that you were mentioning about family history and verification, all the issues that go on in our counseling setting?
Sure. I mean, I think there could be.
Because that's an inexpensive thing, right?
Yeah, it could be inexpensive, and who knows what you can get paid for.
So,
can I add something? So in the JEPAR-6 trial, where they compared carboplatin versus not in triple negative breast cancer patients for the neoadjuvant setting, those patients that had a family history positive for breast cancer had a 57% response compared to 30% without the family history. So I think for us that we don't have genetic testing available in most of our cases, that component might be very helpful to decide whether or not to add carboplatin.
But Cynthia, I think you're raising a different issue, if I may say. The question was, in the absence of most centers in South America and elsewhere around the world not having access to the laboratory estimation of BRCA1/2 mutation, would you recommend, as you are doing in Monterey, would you recommend a genetic counseling clinic to do a deeper dive into the data around the family history before making a decision? Or is it triple negative and any family history good enough for you to assume a mutational analysis?
I would say we did a study, 50-year-old or less triple negative breast cancer patients. There were 200, and in those, 23% had a BRCA mutation, and if they were less than 40 years old, 30% had a BRCA mutation. So, well, yes, if we have available genetic assessment, I think that would be worth.
Would you mind, Cynthia, for the benefit of South American doctors, to mention your study with the City of Hope Hospital on BRCA 1-2 analysis?
Yes, so City of Hope has a registry, a prospective registry, where in the U.S. and in several sites among Latin America, specifically Mexico, Brazil, Colombia, as far as I know. And they are doing the genetic testing for free with a special panel called Hispanel, where they test 114 prevalent mutations among Hispanics. It's without cost. It's a research project, and it has an 80% of sensitivity and a 100% of specificity. So we have been doing this for 3 years now.
Other people can get onto this collaboration, right?
Yes. So I've been referring the interested people to Dr. Jeffrey Weitzel, who is the PI of this important
club. Thank you very much. So perhaps the second question is a provocative one. Hugo, do you want to just mention your second question?
Well, the optimal treatment for a small node negative, triple negative breast cancer, is observation an option?
So in other words, you don't mean no after surgery, obviously, but you're asking, is avoiding adjuvant chemotherapy ever an option in a triple negative tumor? So perhaps I'll pick on like Jack Urban first to just give us your view of small triple negative cancer as relates to adjuvant chemotherapy.
Oh, Paul, thank you. You know, these are very, very tricky. I would have to say yes, but I think that the criteria that I would use are several. First, a T1A is not a T1A. There could be multifocal invasive disease in an area of DCIS, and I view that somewhat differently biologically than a single focus of 2 millimeters or 3 millimeters of invasion. So I would want to look at the pathology very carefully to see whether or not we're really talking about unifocal disease as opposed to a multifocal disease. In this case, I would think somewhat carefully about that and the possibility of retreatment with adjuvant therapy with, for example, a non-anthracycline combination of docetaxel and cyclophosphamide would not be out of the question for me. I believe activity has been established. I would not be enthusiastic about a platinum-based regimen without more information about family or genetics.
I think the current, if I'm speaking out of turn, tell me, but the current policy at MGH is not to use platinums routinely, but to give them in proven mutational analysis patients. So if a patient has a BRCA1-2 mutation proved, we tend to introduce platinum, but that's the only circumstance in which we use platinum, either in the neoadjuvant or adjuvant setting at the moment. For triple negative.
And I think that's ours as well. I perhaps might make an exception if I had a 30-year-old where the family history was either incomplete or strongly positive and testing couldn't be completed.
I know there are other people. Thank you very much, Jack. I think you've expressed the opinion of most people online. I'm going to take the prerogative of saying so. Michelle, can we go back to you after the
But I just want to be clear, you know, I think that originally this tumor was excised. It was 7 millimeters. It could have been multifocal in that nature, but I think even in that setting, a priority, we would have not offered neoadjuvant chemotherapy because remember the original core biopsy was high-grade DCIS. And we certainly, for a 7 millimeter tumor, wouldn't have included a platinum-based agent. Our neoadjuvant protocol that's open right now is for tumors that are greater than 2 centimeters. If they're carriers, they get randomized to receive AC or a platinum-based chemotherapy on the INFORM trial.
So I think we might have mixed up two thoughts. I wasn't implying she should get it. I'm saying when we give it a neoadjuvant.
But Sophia was talking about.
Okay, right. So, okay, I think we've got consensus on that. do you want to go back to after the recurrence in this patient without mutational analysis being performed? Is now bilateral mastectomy an option or the option of choice?
It's not the option. It's always an option. We know the contralateral prophylactic mastectomy doesn't afford any increase in overall survival. Many women choose it because they don't want to go through the screening, but we carefully caution them that, you know, if there was an infection in the contralateral breast, if there was something that could delay her systemic therapy, if that's what she needed, that's a problem. So it's always an option, but we certainly don't force it upon anyone because there's no survival benefit.
Shyla, I can see you nodding your head. Do you want to add something surgically to this?
What we do know is that, you know, the oncologic principles take first hand. So getting a tumor out, negative margins, orienting the margin, we all know that. But if you can do that, you have to keep in mind their cosmetic outcome. And so we know that women that have a unilateral mastectomy with implant reconstruction, their satisfaction long-term is very, very low. So sometimes if you're in a community where all you can get is implant-based reconstruction, you have to consider a contralateral mastectomy for symmetry procedures and their bras fitting properly and their clothes fitting. It's not for survival, but their quality of life is significantly impacted by how they look in their sexual life.
Alfonso, are there any radiation? Thank you, Charlotte. Are there any radiation issues here?
Yeah, a couple of comments. Just in general, and there is quite a bit of data on that, that the risk of local failure for triple negative patients is significantly higher than luminal A or luminal B. So when you look at the data, you will see, let's say, at 5 or 10 or 7 years of follow-up, luminal A will have 2% local failure rate. You will see the triple negative will have 7%. So it's almost 3.5 times the luminal A. Compared to HER2 positive patients, before Herceptin, it used to be 11, after Herceptin is much less than that. So we still struggle with the local failure rate for triple negative. Would like to bring it down to be close to 2 or 3%. And there are some trials here and there, like actually giving concomitant cisplatin with radiation, and this is a trial from the Brigham that we also accrue for it here. But they have they include only 2 centimeter triple negative. So triple negative is an issue with local failure. I don't know how to overcome this, whether by adding something concomitant to this or increasing the boost, and nothing really is there is no solid data for this. What worried me here is that she had the local failure right away within a year or 2. And I don't know if this might reflect that maybe some DCIS were left behind. The radiation was absolutely fine. This is the British hypofractionation, which gives very, very good results. But it's just surprising that it came rather quickly. And then just the only treatment for this patient now is mastectomy.
So, Hugo, just so we can catch up with time, please forgive us for avoiding your second case right now. And can we jump straight to Nelly Velikova, who is presenting from Sofia in Bulgaria? Nelly, can you hear us? Please turn on your microphone.
Hello, can you hear me?
Yes, we can. Thank you.
Okay, thank you for the opportunity to participate in this tumor board, and good morning to everyone. So I'm going to present a case about 47-year-old premenopausal woman, previously healthy, with no comorbidities and no family history of breast cancer. She experienced a myomectomy in the past in 2009. Next, please. In the end of 2014, her screening mammogram showed suspicious mass in the upper outer quadrant of the left breast by RADS4. The diagnostic ultrasound and MRI confirmed 1.2 centimeter spiculated nodule at 2 o'clock left breast, 4 centimeter from the nipple, with no suspicious axillary lymph nodes. Fine needle aspiration was positive. The staging workup showed no metastasis, and the patient proceeded to surgery. Quadrantectomy and axillary lymph node dissection was performed. The pathology report showed invasive lobular carcinoma, 1.1 centimeters, grade 2, with multiple foci of lobular carcinoma in situ. The margin showed atypical lobular hyperplasia with 1 focus of lobular carcinoma in situ. 14 axillary lymph nodes were removed, and 2 of them were positive for metastasis with a diameter of 0.1 centimeter. The patient is ER positive, HER2 negative, and Ki67 is 10%. So it was discussed with the patient in another hospital, and she decided to proceed with bilateral skin sparing mastectomy and immediate breast reconstruction. After the surgery, the pathology was negative, and the post-surgical MR showed normal position of the silicone implants, but a residual, significant amount of residual breast tissue bilaterally. Next. The diagnosis is breast cancer, stage 1B, PT1C, PN1MI, M0, invasive lobular carcinoma. The patient underwent 6 cycles of adjuvant chemo with AC. Radiation therapy was performed to the left breast and the regional lymph nodes to a total dose of 46 grays in 23 fraction. And 3 months after the radiotherapy, the cosmetic result is excellent. And tamoxifen was prescribed as endocrine therapy. So our fourth question is there any role of prophylactic contralateral skin sparing mastectomy for invasive lobular carcinoma?
If you just stop there, we'll discuss that point. Michelle, do you want to comment on that?
Well, I mean, Alphonse, why don't you comment on our data looking at LCIS at the margin and HPA-side? I might have stopped at lumpectomy. Quadrantectomy.
Yeah, LCIS at the margin does not increase the risk of local failure. That's different than DCIS. And we've published a paper about this maybe like a few months ago on more than 1,000 patients. When we have DCIS at the margin, we try to achieve negative margins, which is per the new guidelines, no tumor on egg. But when we have LCIS at the margin, we do not try to achieve negative margin because there is no evidence that LCIS at the margin increase the risk of local failure.
Does it influence your subsequent boost, whether you have
Absolutely not. It's as if it doesn't exist for some reason. I think we rely more on tamoxifen or hormonal therapy. So that's important. Do you want to continue with the regional lymph node, or do you want to go on?
Skin-sparing mastectomy.
Yeah, I mean, so honestly, as a surgeon, I probably would have cautioned her to stop at lumpectomy. We know, that there's probably, and this is a bit controversial, a role for radiation therapy after a mastectomy. But certainly I would have felt better knowing she had stopped at lumpectomy with the 2 positive nodes and just irradiated her. Sure, you can do a prophylactic contralateral mastectomy. I think that some of the ideas that were historic, where people would have mirror image biopsies of the contralateral breast looking for lobular cancer, have been debunked. And I think that's just because we're increasingly relying on adjuvant endocrine therapy in an extended fashion, beyond 5 years, that helps control that disease. So for me, just because someone has lobular cancer does not mean that they're going to automatically get a bilateral mastectomy.
Charlotte, would you want to comment, or you agree with that?
I agree completely.
Okay. So maybe, Alphonse, there's a question here. If I may just jump in, Nelly, forgive me. Radiation after skin-sparing mastectomy and breast reconstruction, as a general point. How about?
Yeah, I mean, if it is indicated, I would argue in this situation here, you had a small tumor which is ER positive. She didn't even need any chemotherapy, and she had a mastectomy. Although she had like 2 tiny micrometastases.
She got chemo.
She get 2 tiny micrometastases. I would have questioned whether this patient actually needs post-mastectomy radiation. The issue with post-mastectomy radiation is basically the data is based on the overguard data. And the overguard did lymph node dissection to everybody, although there is some question of the number of lymph nodes removed. But they didn't really break down into micrometastasis or macrometastasis. This could be in a gray zone area. Should we give post-mastectomy radiation or not? But assume we give post-mastectomy radiation after reconstruction. There are quite a bit of side effects which can impact the reconstruction. And the rate of complication with radiation is actually can go up to 20 or 30%. It goes from like reasons to remove the implant, so all the way into encapsulation, into retraction, into hardness, into tenderness, into like the implant moves upward, and then this requires some correction from the plastic surgeon. So we take it very seriously when we give radiation after implant, but when it is necessary, I think having a local control has a lot of like more benefit than having a poor cosmetic product. So that's the impact of radiation on reconstruction.
Maybe I can jump in with another point, and I'm going to pick on Susan. Can you hear me, Susan? I'm just curious about her, being a 47-year-old woman with a small tumor. This is a small point, but what is the role of staging investigations? This patient was fully staged at diagnosis. Is that a routine for such an aged patient with an ER-positive tumor that is so small? And secondly, do you agree with the adjuvant AC ×6 chemotherapy?
So in terms of staging, assuming she didn't have any systemic symptoms, bone pain, anything like that, normally we would not do a full staging evaluation in early stage disease. Regarding, what was the second question, Paul?
About your adjuvant AC ×6.
So given that this is a left-sided tumor, I guess my preference would have been to give less adriamycin. So our standard here would be to offer her AC ×4 cycles and then on to Taxol. I think with the modern radiation techniques, there's less risk of cardiac toxicity, but I'm an old-fashioned practitioner. I still worry about small risk long-term with a higher dose of adriamycin as well as the radiation therapy.
Jack, what about TC? Do you want to just comment about TC or alternative chemotherapy approaches to this patient?
Yes, thank you. I would agree with Susan. I think the CALGB looked at 4 and 6 cycles of adriamycin and showed there was no advantage to 6. And TC for 4 treatments compared to AC for 4 treatments has clearly been shown to be superior in terms of efficacy for node 0 to 3 node positive in particular. I think there's good data for that. I do also think it has the advantage of eliminating the cardiotoxicity issues, and so I would find that to be a positive option for a patient like this.
Thank you, Jack.
Would anyone send an oncotype and not give chemo?
Send an oncotype and not give chemotherapy is one suggestion by Michelle.
If she was post-menopausal.
Well, right. I would be not as enthused because she's not really in an age where the oncotype has really looked at node-positive women. If you consider her node-negative by virtue of micrometastatic disease, perhaps, but classically, I think the data only really extends to postmenopausal women at this point for node-positive disease.
So staying with you, Jack, there's a question here about, if I may, just ask the question for you, Nelly. Prognostic significance of micrometastatic lymph nodes, less than 2 millimeters after ALND, and the indication for adjuvant chemo and regional lymph node radiation. In other words, yeah, go ahead, Jack.
Yeah, so I was impressed with the paper in the New England Journal a few years ago where ITCs, at least, or a minimal disease in the nodes, really wasn't prognostic so long as the patient received the proper adjuvant therapy. In fact, in other words, adjuvant therapy sort of neutralized any finding in the nodes. I don't know if it really extends to micrometastatic disease, but I would say that it is meaningful, but I think it's probably largely neutralized by modern adjuvant treatment.
Anybody want to comment on that point? Susan, do you have any extra comments? No, okay. And what about radiation?
Yeah, I would certainly not give regional radiation for this situation. Actually, we have the Z11 study, which did just sentinel node, not even lymph node dissection, just sentinel node. And when the node was positive, we just gave high tension as radiation oncologist, and we don't do lymph node dissection, and we don't do regional lymph node radiation. Just bear in mind that lymph node dissection will cause 18% risk of lymphedema. And then if you add regional lymph node radiation to that, the risk of lymphedema will be 24%. So that's a lot of complication for two tiny positive lymph nodes. So in retrospect, what I would have done, I don't know if sentinel node is being done or not in this place, but if it is, you could stop. You don't need to do lymph node dissection after a small, tiny positive lymph node like that. And just like give the treatment of the axilla to radiation, because she will get radiation anyhow. And I would just do high tensions, which will cover the level 1 and 2 in the axilla.
Now, Anita Medical, like Susan, I'm going to hand you the question of what are you doing in the era of post-text, post-soft data. This is a perimenopausal, declared premenopausal 47-year-old patient with an ER-positive breast cancer. And the question is, what is the choice of optimal adjuvant endocrine therapy, and what is the duration? What is the duration? So if you could just address this whole point, that'd be good.
Well, I guess the most important thing is to develop a regimen that a patient's going to be compliant with long term. So I think based on the soft and text study, the ideal treatment in my mind for someone who's a higher risk that you've given chemotherapy to would be to offer them ovarian suppression with an aromatase inhibitor. Having said that, many women cannot tolerate that. So this patient I would view as not in the highest risk category to really say dogmatically this is what I would prefer, but that would be the best therapy available. But in this particular case, I think I would have an honest discussion with her about various side effects, comparing ovarian suppression, starting that with one first month, and then maybe adding in the aromatase inhibitor at month 2. If she didn't tolerate ovarian suppression, then you could back off and think about extended tamoxifen, or starting with tamoxifen and switching to an aromatase inhibitor once she's clearly postmenopausal.
So I think, Susan, you're saying that I think a trial of endocrine therapy is always the appropriate way to address patients. Anything we give, tamoxifen, ovarian suppression, or anything, is always a trial. And I think in the first 3 months, patients sort of know how they're going to be on the treatment. I think patients between 45 and 55 are most vulnerable to side effects from endocrine therapy, more so than younger women and older women. So I think those are the problematic patients. She's in a problematic age and may not tolerate. But the good thing is these days we can reverse any kind of endocrine therapy decision, so that's good. And then I think that in my own mind, actually, it doesn't matter what kind of endocrine therapy you give, it's so much better than none. And any kind of endocrine therapy is a lot better than none. When you're talking about what kind of chemotherapy, you're talking about a difference between last year's model of a motor car and this year's model. But the difference between having a motor car or not is the big difference. And having some form of endocrine therapy, I think, is important. And in 2016, we are hoping to present data on MA17R, which will talk about 10 years of aromatase inhibitor rather than 5, as is the NSABP B42 trial going to present. So a lot of patients are asking after 5 years, should I continue my aromatase inhibitor or not? For the time being, I'm continuing because we're on the brink of a result. So for those patients where there's indecision, why not just continue if they're tolerating it well and have no financial duress or anything? Continue it until the results are available. But at the end of the day, longer endocrine therapy seems to be better than shorter. That's what all the data is pointing to. So some form of endocrine option is probably preferable to, and longer is probably preferable to not. So that's my overall opinion about that subject. And then there's a question here about the best imaging modality for follow-up. I don't know quite what the question is. Michelle, can you comment on an invasive lobular that's been excised or had a mastectomy?
So with a lumpectomy, if she had completed the lumpectomy, it would be yearly screening mammography. We don't necessarily add breast MRI to one screening and follow-up if they've had a lobular without a family history of breast cancer. In fact, I would argue that their risk of creating a new cancer in the contralateral breast is improved because of the hormonal therapy they're on for the treatment of their known breast cancer. After bilateral mastectomy, I know that in this situation you had noted some residual breast parenchyma, so it's kind of an interesting, different situation. But we would, not do any imaging. Even our plastic surgeons feel like imaging the implants is not a have to, and really any issues that we have with regards to implants are things that we can detect clinically. So it would be a yearly clinical exam by a surgeon and a yearly clinical chest wall exam with the other physicians involved in their care, the medical oncologist and the radiation oncologist.
I think we're running close to time. Thank you, Michelle. Maybe we'll have Pierre and Cynthia present their case from Monterrey in Mexico, please.
Hello, can you hear me?
Yes, Pierre, thank you. We can hear you. Please go ahead and present your case.
Good morning. Our case is a 38 years old premenopausal woman with and now with breast cancer at age 50 and other risk factors. In the third trimester of 2015, she self-palpated a right breast nodule. A mammogram was performed, and after that, mastectomy plus axillary lymph node dissection was performed. In the pathologic report, an invasive ductal carcinoma was documented of 2.5 centimeters with SBR of 7, lymph vascular invasion positive, negative surgical margins, and one lymph node positive for a metastasis of 7 millimeters. The immunohistochemistry report estrogen receptors positive with R7, progesterone receptor negative, 2 negative, and a Ki 57 of 50%. 1 month later, the patient presented to our center to advise adjuvant treatment. Next, please. So we have a patient with breast cancer stage 2B, and we indicated adjuvant chemotherapy with dose dense of AC followed by paclitaxel, and the first cycle was on November 5th. A genetic risk assessment is pending. Next.
So we have several questions regarding this case. So the first one is, what would be the optimal adjuvant hormonal therapy for her, being a 38-year-old woman with an N1 grade 2, and if we would consider extended therapy or ovarian suppression, and we would like to know your opinion about if we should consider for all premenopausal patients the combination of OFS plus adjuvant aromatase inhibitors.
So that's a very clear question. Jack, could you tell us your view after soft and text? What do you do with premenopausal patients who are already receiving adjuvant chemotherapy for perceived risk? Well, how do you manage their endocrine therapy?
Yeah, so this patient clearly does have major risk issues. She's 38. I would consider her probably closer to 35 than 40. She's requiring chemotherapy. She's PR negative. There's a whole host of factors that make one want to be concerned about her prognosis. But it's important to remember that the patients who entered SOFT were really premenopausal, if you will, by virtue of their estradiol levels or continuing to have menstrual function. And so I think it shouldn't be yet, in my opinion, and Paula would certainly be the expert, certainly yet wouldn't be my practice to put all patients on therapy. Going back to ECOG years ago, the addition of Lupron without tamoxifen did not add to chemotherapy in the premenopausal woman who had just completed chemotherapy unselected. So I would follow the standards of SOFT. I would want to know what her estradiol was before committing her to ovarian suppression.
I think, may I say that I think that not all hospitals attending this tumor board will have an easy estradiol assessment available, and particularly as the levels decline toward menopause and into menopause. Most hospitals don't have that technology. But the question really, Jack, I'm going to push you on this a bit. The question from Monterrey, from Mexico City is, if you've already decided the patient is justified to give chemotherapy, I think you've answered this, does the administration of chemotherapy mandate a soft text approach because they were considered requiring chemotherapy? I think that's the question.
Yes.
So if I could make it a little bit cleaner and make her just a little bit younger, and I would have to say that I think the evidence is compelling that a very young woman in her 30s with node positive requiring chemotherapy, hormone sensitive, probably should have additional combined therapy. And the question of the aromatase inhibitor versus tamoxifen, I think, deserves a second discussion, and in some cases will be correct. So I think, yes, ovarian suppression should be considered.
Okay. Any agreement or disagreement with that, Susan?
Yeah, so I think if you look at the published data, I mean, the patients who received chemotherapy and who were part of these studies were a group, regardless of age, that benefited from ovarian suppression. So looking at the data of tamoxifen versus ovarian suppression with exemestane, the difference at 5 years was like 7%.
Okay, so that's pretty convincing for you.
Yeah, so if you don't have access to hormonal levels, you could start with tamoxifen, and then if she gets a period, add in ovarian suppression, or take a different approach and say that the majority of women treated with ACT at this age will resume menstrual function within a year and just be aggressive with the treatment of her breast cancer.
I must say I'm inclined to be in that camp of thought. I agree that she's going to be premenopausal at 38 regardless of what happens, I think. So I think that at least here, I know several of my respected medical oncologists would agree with that opinion that Jack and Susan have just given. If anybody disagrees, please say so. But I think you're hearing that a soft text approach should be given to patients with chemotherapy, adjuvant chemotherapy. So
Paul, I would just add one that I think the B30 trial was very informative as to who would or wouldn't become menopausal based on chemotherapy, and by age, I think you can get some very nice data as to what that outcome is going to be.
Okay, I'd like to ask Cynthia to give a second question, the next question.
Can you put the presentation, please, again, Jessica? Or I can see it over here. So,
just one second.
The second question is, what is the role of adjuvant bisphosphonates in premenopausal patients that receive ovarian suppression, and if there are any other features that guide us on this decision?
Another very good controversial issue, and I'm going to turf the ball to, let me give it to Susan first. Susan, do you routinely give bisphosphonates? There are two questions buried here, I think. The first one is bisphosphonate desirable for a young person getting ovarian suppression for bone metabolism reasons? And I think the answer to that is yes. For 1 year at least, definitely. But the deeper question is, with the presentations that have been given at the major meetings, is adjuvant bisphosphonate now a routine anti-breast cancer 5-year adjuvant therapy in all patients? In whom should it be given? When should it be given? That's the question.
Yeah, so I think, again, this is a controversial issue. So in my young patients who I'm offering ovarian suppression as their primary endocrine therapy, particularly with an aromatase inhibitor, those are the patients that I'm normally recommending bisphosphonate for. Based on the SWOG study, I think you have your option right now whether you use an oral versus an IV bisphosphonate, but I would consider in this population that would be standard for me, although I think the national guidelines and NCCN are still not quite certain who to give bisphosphonates to.
Susan, can I interrupt you? Are you influenced if the patient expresses interest in subsequent pregnancy by the use of bisphosphonate or not?
Ooh, you know, I honestly don't know that data, Paul. My guess is that would make me nervous, but I have not researched that. Does anyone else who's listening know that answer?
Yeah, hi. I would be very nervous. I think the evidence, at least in clinical studies I'm aware of, is that you can measure terminal half-life of excretion of the drug even a year out from a dose. There is drug that is stored and slowly released over time, and so I think it would be, in my practice, an absolute contraindication if somebody were considering future pregnancy.
Either oral or IV bisphosphonate.
Yes, I would avoid that because of the long half-life in the patient.
And then the question that I should probably answer, but I'll let others answer. What about denosumab? Would you consider denosumab differently or the same?
That's a great question. I truly don't know the evidence for the terminal half-life, but I would say any drug that could exist in the body for a long period of time, I'd be nervous about.
I think denosumab's got a long half-life like most antibodies, but not as long as the as Meta or those other agents. But I think that in patients wanting children or pregnancy after treatment, I think bisphosphonates currently are still contraindicated, actually, and probably denosumab as well because of possible teratogenicity.
Yeah, so Paul, I just researched that quickly as we were talking, and both of those agents are contraindicated with pregnancy. So.
Right. Thank you, Susan. That's great. So, Cynthia, is that the answer you were looking for, or did you want to probe deeper on this question?
No, it was that, because then in the meta-analysis, even the patients that were deemed postmenopausal were the ones that benefited. So.
And I realize I've got two experts on the line that I haven't asked the question of. So the radiation question that's next, perhaps Dr. Carol Marquez can address, and then and as well the last question. So Dr. Chu, maybe you'd like to say something as well about post-mastectomy radiation for this young patient. So you ask the question, Cynthia, please, the last two questions.
So the question is, the third one, what is the role of post-mastectomy radiotherapy for this young patient with a T1N1, with a 1 positive, HR positive, hormone receptor positive, HER2 negative breast cancer? And should all young women with 1 to 3 positive nodes should receive adjuvant radiotherapy?
So,
it's Julia.
Julia, yes, please.
Yes, hi. So the question is always debated at our own tumor board at Penn. So because of your young age and her having 1 positive lymph node, we would err on the side of being more aggressive and will most likely recommend post-mastectomy radiation at our institution.
Maybe Alphonse, you want to add something to that? Dr. Marquez, would you like to say something, please?
I'd agree with that, and I'd agree with it also because of her other negative features, which would include the LVSI and the size of the tumor. I think all of those features together would make me recommend radiation for her.
And Alphonse is nodding his head.
Absolutely right. It's beyond the age. It's beyond 1 positive lymph node. There are a lot of other features which really bring her risk a little bit higher. So I fully agree with you. We look now at multiple risk factors. We look at the big picture, and instead of being cornered into 1 positive lymph node should have post-mastectomy radiation. So she has LVI, she's young, she didn't have enough lymph nodes removed, and the tumor was large, and so she had multiple risk factors. I agree with you.
Can I add something? But if otherwise we would have positive features, luminal A breast cancer with a grade 1, but with 1 to 3 nodes, age would guide you towards giving radiotherapy?
I mean, in regards to your last question, so like what you're saying is, just because she's young and just because she has 1 to 3 positive nodes, would you always give radiation? I don't think that's the case, because I think, as we discussed in the previous case, I think it depends on the amount of the nodal burden, how involved the node is, I think it does depend on the pathologic subtype, and I think the presence or absence of LVSI is really an important feature in determining local regional recurrence after a mastectomy. So I think it is, as Dr. Takian says, a kind of looking at the whole picture, at the whole combination of factors, not just age and positive nodes.
Right. Thank you very much. You agree. Alphonse agrees again, so we've got consensus around that. Thank you, Carol. Thank you very much. Thanks, Dr. Chu.
Okay.
You know, we're a few minutes early, but I'd like to ask Hugo if we can keep your... We'll hang on to your second case, and we'll give you a chance to present it at a subsequent tumor board. And I'd just like to repeat what I said in the beginning. If everybody would do us a favor, for Jessica, for all her hard work arranging these tumor boards, if you wouldn't mind, somebody with a cell phone, if you could just stand up in front of the room, or if you're a viewer and you're watching on your own laptop, but there are 2 or 3 of you, anybody with anyone else in the room or just by themselves, could you take an iPhone snapshot, either a selfie or of the room around you, and send it to Jessica sometime after this tumor board? Thank you very, very much, everybody, for your attendance. I hope it was a good tumor board. Thank you.
Thank you.
Thank you.